the microphone over to Dr. Suzanne Chang, Director of Neuro-Oncology Supportive Care Services at the University of California, San Francisco. Dr. Chang is an internationally recognized leader in the field of neurological malignancies. She specializes in the treatment of adults with brain tumors, including glioblastomas and meningiomas. Dr. Chang's research expertise is in clinical trial design and development of novel therapies and imaging biomarkers for brain tumors. She is involved in more than 20 active clinical trials. Dr. Chang is especially dedicated to improving the experience of her patients and their families, with a particular focus on increasing quality of life. She is the founder and director of the UCSF Neuro-Oncology Gordon Murray Caregiver Program, which provides resources and support to the caregivers of brain tumor patients. She is also the co-director of the Sherry Sobrato Brain Cancer Survivorship Program, focused on comprehensive survivorship care for brain tumor patients. Dr. Chang.
Thank you so much, Lacey, and good evening, everyone. It is really an honor to be here with all of you during this exciting time when we actually have some transformative areas in the treatment of brain tumors. The Sherry Sobrato Brain Cancer Survivorship Program is proud to sponsor today's webinar as we continue our commitment to being at the forefront of patient care and support. And our program is really dedicated to addressing the unique needs of all of our patients, and we're constantly evolving to serve you better. Now, harnessing the immune system has been effective in several cancers, and this is being tested for brain tumors also. So we're very excited that Dr. Hideho Okada and Dr. Jenny Clarke are here to share their knowledge and expertise on the topic of cellular immunotherapy for brain tumors. So Dr. Okada is a professor of neurosurgery at the University of California, San Francisco. He's a member of the Brain Tumor Center and the Parker Institute for Cancer Immunotherapy. He is a physician scientist who has studied immunotherapeutic strategies for treating malignant brain tumors in a laboratory and has translated them into clinical protocols. Dr. Jenny Clarke is a professor in the departments of neurology and neurological surgery, and she's an outstanding neuro-oncologist and specializes in novel approaches to the treatment of brain tumors in adult patients. In addition to clinical care, she has extensive experience in clinical trial development, implementation, and analysis, and is involved in numerous clinical trials. Dr. Okada and Clarke have worked collaboratively for many years and are the principal investigators on several immunotherapy trials. So at UCSF, while advancing research and exploring new therapies remain a core focus, the voice of the patient is often as powerful as that of the physician or researcher. And that's why we work to integrate their perspectives into everything we do. By weaving their experiences into educational materials and care strategies, we bring this work to life in ways that truly matter. So we're so grateful to Douglas Labatt, who will share his experience in participating in a clinical trial evaluating cellular therapy. So thank you all very much for attending, and we will start with Dr. Okada.
Let me share my screen. Good evening, everyone. I hope you see my slides okay on your computer screen. It's such an honor for me to be with you tonight talking about immunotherapy, specifically CAR T therapy. So I'm going through the basics of immunotherapy and CAR T therapy in a way I hope you understand, but please feel free to ask any question through the chat system. I'm happy to answer any question you may have. So to begin with, what is immunotherapy? As a first step to understanding immunotherapy, let's review the role of immune system in our body. Our immune system is fascinating because it is our body's natural defense force against anything that is bad coming from the outside of our body. It is made of many types of cells and molecules that work together to find and destroy harmful invaders, such as viruses and bacteria. The immune system can also detect and eliminate cells infected with viruses. Among many immune cells, T lymphocytes, we also call them T cells, are the central players for these processes because they can find unique signatures, what we call antigens, of pathogens. These same defenses can work against other abnormal cells, including cancer cells. What happens, however, when cancer evades the immune system? Cancer cells are actually tricky. They can develop ways to hide from the immune system, disguise themselves as normal cells, or send stop signals that shuts down immune attack. When this happens, the body's natural defenses can no longer keep the cancer in check. The ideas behind cancer immunotherapy is a form of cancer treatment that helps the immune system recognize and fight cancer more effectively. That can be done by a variety of different ways. Boosting the activity of immune cells that can attack tumors, or removing brakes that cancer places on the immune system, or training or engaging engineering immune cells to specifically target cancer cells. So these can be done in combination, as I'm going to talk about combination later. The ultimate goal of immunotherapy is to restore the immune system's ability to identify cancer as a threat and eliminate it, much like it would do against a dangerous infection. Here are examples of cancer immunotherapies. So first, boosting the activity of immune cells that can attack tumors, such as drugs that wake up immune cells by mimicking danger signals, like pieces of bacteria or viruses. Removing brakes that cancer places on the immune system, such as immune checkpoint blockade, that takes the brakes off the interaction between immune cells and cancer cells so that T cells can attack cancer more strongly. Or training or engineering immune cells to specifically target cancer cells, for example, cancer vaccine. This is a treatment that trains the immune system to recognize cancer. Well, adoptive cell therapy, such as CAR T therapy, this is an infusion of a large number of immune cells that are trained or engineered to attack tumor cells. Let's move on to talk about what CAR T therapy is. So it is a type of immunotherapy using T lymphocytes that are engineered to effectively target cancer cells. CAR, C-A-R, stands for chimeric antigen receptor. This is a man-made GPS and weapon that is built into your lymphocytes, such as T cells, helping them find and attack cancer cells more precisely. T lymphocytes, again, we call them also T cells. Those are white blood cells that act like body's soldiers, finding and killing infected or cancerous cells. Therefore, CAR T therapy is a cutting-edge form of immunotherapy that genetically engineers your own T cells with CAR to fight cancer. So think of this as taking your body's natural defenders into a special training camp, upgrading their GPS, and sending them back as elite cancer hunters. So how it works? Let's go step by step. The first step is a procedure called leukapheresis. So it is for collecting a large number of white blood cells from patients' blood. As a second step, those T cells are selected and activated before engineering with the CAR gene. Then T cells are engineered with CAR in the laboratory. Then those engineered CAR T cells are further grown in the laboratory. As a next step, CAR T cells undergo rigorous tests for safety and functions. before going to patients. And also, patients may receive what we call conditioning chemotherapy before the infusion in order to enhance the function of CAR T cells after infusion. Then finally, CAR T cells are infused to patients. So why is CAR T different from traditional treatments? I would say traditional chemotherapy acts like a carpet bombing, attacking cancer but also harming many healthy cells. CAR T therapy is more like a launching smart missiles. They are programmed to seek out only the cancer cells with a specific target. Instead of adding foreign drugs, CAR T therapy empowers your own immune cells to become the treatment. So I'm stopping my section and I will hand it over to Dr. Clarke for the next section.
Thank you, Dr. Okada. I'm going to go ahead and try to share my screen properly here. All right, are you seeing the correct view? Okay, good. So we're now going to focus a little more specifically on CAR T cells in brain tumors and what we know so far. There are several extra challenges with dealing with tumors in the brain. First and foremost of which is one you're probably familiar with, the blood-brain barrier. This is something that's evolved over thousands of years as part of our defense systems. I would argue that the brain is the most important organ in the body, and so it's got an extra layer of protection to keep safe from invaders, such as infections, but also to keep safe from toxins or poisons, which, for better or for worse, include many of the medications that we try to use to treat people and treat diseases. The blood-brain barrier is, the core of it is really the wall of a blood vessel. These are endothelial cells, and they're very closely related to these foot processes from astrocytes. The true core of the blood-brain barrier are these little proteins that bind the endothelial cells together in what are called tight junctions, and they prevent molecules and cells and other things from being able to move easily in and out of the bloodstream in the brain. This is another view of the blood-brain barrier, just with a cross-section through a vessel, so you can see the endothelial cells going around with the tight junction, the astrocyte foot processes, and other cells called pericytes. Not parasites, but pericytes. It's a tricky pronunciation. The second major challenge with dealing with tumors in the brain is something that the brain tumors share actually with many other solid tumors, and that's the fact that tumors can develop what we would describe as an immune suppressive tumor microenvironment. And this includes some of the things that you've recently heard about, but specifically, there are blood cells that are in the immune system that are patrolling and trying to fight tumor, being anti-tumor, but tumors themselves secrete different proteins called cytokines and other things that either make it harder for the immune cells to see the tumor or shut off the function of the tumors of the immune cells, or even potentially actually cause the immune cells to break down and die. And so that allows the tumor to continue to hide out without being detected by the immune system. The third challenge that I'm going to talk about is what I call tumor heterogeneity. And what that means is that not every tumor cell looks the same or expresses the same proteins or antigens to allow us to be able to target them. This is what the ideal situation would look like, where every tumor cell expresses the same antigen, allowing us to be able to recognize them easily with our CAR T cells. And conversely, in the rest of the body, none of the cells express that same antigen, so we have no worry about any type of cross-reaction. That would mean that our CAR T cells, when they're circulating, only bind to cells in the tumor and kill those, having no effect on the rest of the body. The reality, unfortunately, is a bit more complicated and kind of looks like this. You don't need to understand all the nuances here, but the idea is that the tumor, as it lives within the brain, has actually multiple different environments within it. There are areas that are close to blood vessels, what we call perivascular niches. There are areas that are far away from the blood supply that are hypoxic or necrotic. There are areas that are close to the ventricle, what's called the subventricular zone. And there are cells that are invading or crawling further into the brain, either along blood vessels or along white matter tracts. And the tumor cells in each of these different sub-environments are behaving differently and functioning differently so that they're potentially expressing different proteins and they don't look the same to the immune system. And so that's a really big challenge. There's a cool concept technology that has been developed at UCSF, specifically in Dr. Wendell Lim's lab, that is a way of trying to help CAR T cells to circumvent this set of challenges. It's called the SYN-Notch CAR T system. And the way this works, the cells to start out with are not full CAR T cells, but they're expressing this SYN-Notch receptor on their surface. And this receptor is looking for an antigen that we'll call A to start with. Only if it sees antigen A will it then activate and start producing the CAR cassette that is actually targeting a different antigen, which we'll call antigen B. The idea here is that if you have a very specific antigen A that is only expressed in some of the tumor cells, but isn't expressed anywhere else in the body, and you have an antigen B that is expressed in all of the tumor cells, but also can be expressed in other parts of the body, we can take advantage of that. And specifically, within the tumor, the CAR T cell or the SYN-Notch cell binds to antigen A, which activates it and then kills all the cells that are expressing antigen B. In the rest of the body, then, where antigen B is found, but there's no antigen A, the cells never get primed and nobody gets killed. So this lets us really take advantage of some of the specificity that we can use. And in particular for glioblastoma, our first kind of demonstration of this is involving a protein called EGFRV3 that's acting as our priming antigen or antigen A. And then that activates a CAR T cassette that then is targeting two different antigens to kill cells. And it can bind either FA2 or IL-13 receptor alpha. And so as long as the tumor cells express one or the other of those, they're vulnerable to being killed. So we have a clinical trial going on right now that is a phase 1 trial or a safety trial. We are testing what we call eSync T cells, and that stands for EGFRV3 SYN-Notch CAR T cells. And we're specifically targeting adults who have EGFRV3 mutant glioblastoma. There are two different cohorts that are enrolling sequentially. So the first one, cohort 1, is what we call a dose escalation cohort. We're specifically testing two different dose levels or amounts of CAR T cells that we're giving people. And we're enrolling patients who have EGFRV3 mutant and MGMT unmethylated tumors, basically right after people have finished their initial chemo radiation. Once we select a dose, we then will enroll into cohort 2, which is what we call a tissue analysis cohort. And this is going to be for patients who have tumor that it makes sense clinically to have a surgery. And in that setting, we're going to treat people with the CAR T cells a few weeks before their planned surgery. We're then going to take the tumor sample that gets removed, and we'll be able to look at whether the e-sync cells are in the tumor, whether they're activated the way that we think they should be by the EGFR V3, and whether they're actually killing the tumor cells. So I'm going to move on now to a new section where we focus on what you all should know as patients about CAR T therapy. I think one of the big questions is always, could I be a candidate for CAR T? It's important to know for solid tumors like glioblastoma or any other brain tumor, the CAR T therapies are currently only available in clinical trials. And many of those trials are targeting people whose tumor is growing back after initial treatment. Whether or not you're a potential candidate for a trial really depends on whether or not you fit the trial's specific criteria. That said, it's worth asking your doctor if there is a trial, either a CAR T trial specifically or an immunotherapy trial more generally, that might be a good fit for you. So what would be involved in receiving a CAR T treatment? As we have described, the first step is the leukapheresis, where we are collecting your own cells to modify. That actual collection takes place on a single day, but it is a bit complicated, and we may need to actually place what's called a central line or a really big IV into one of the big blood vessels in your chest in order to safely collect the cells. Once we've collected them and they are going through the manufacturing process, that whole process takes about 5 weeks from start to finish. Once that's done, if they've satisfied the quality control testing and we're ready to give the cells to you, we then would need to treat you with 3 days of conditioning or lymphodepleting chemotherapy. And then we allow 3 days for the chemotherapy to take effect, kind of rest days. So that takes another week. After that, you get admitted to the hospital because we give the infusions in the hospital. And we actually require people to stay in the hospital for a full week so that we can watch very carefully for potential toxicity, because we don't know exactly when that type of toxicity might pop up. If things are okay and you're discharged from the hospital a week later, we then still do want to be keeping a careful eye on things. And so we require that people stay local, meaning within an hour or two of the hospital, for a total of 4 weeks after their cell infusion. So this treatment is pretty time and location intensive. It's a big commitment. What are the potential side effects that we're worried about? There's 2 big syndromes that we worry about most. The first one is called cytokine release syndrome. This is essentially your body thinking that the CAR T cells are foreign invaders and reacting as if you have a really bad infection. And so the symptoms that can go along with that include the potential for high fevers and chills, trouble breathing, nausea, vomiting, diarrhea, dizziness,
Here, I need to open my
lightheadedness,
little things again and keep them in.
headaches,
Hit the button.
and that sort of thing. The other big toxicity syndrome that we worry about is a neurological one called ICANS. ICANS stands for Immune Cell Associated Neurological Syndrome. And that is something that can happen in people treated with CAR T cells where there's a reaction in the brain, even if there's no cancer in the brain itself to start with. In this setting, we think the CAR T cells are potentially kind of cross-reacting with something in the brain. And it can cause headaches, it can cause changes in people's level of alertness, People can be confused or agitated. They can have seizures and tremors, and they can have difficulty speaking or understanding. Besides these two really big things that we worry about, there are a bunch of other side effects that are possible too. There can be swelling around the tumor. And so if your tumor's in the brain, then that can cause increased neurological symptoms. We worry about the possibility that you have low blood counts and that you could develop infections or that you could have allergic reactions, that your electrolytes like sodium could get out of whack, and some other things. So this is, this is a serious treatment that does have potential serious side effects that we do worry about. That said, there are support systems that are available. Anybody who's potentially going to go through a CAR T treatment, whether it's a standard treatment that's approved or in a clinical trial, has a social work evaluation as part of the preparation to participate. And so social workers like Lacey do an amazing job of helping to make sure that patients and their families understand the commitment that they're making and are set up to be successful in getting through this whole process. We also do have the potential for some subsidized housing near UCSF to make the staying local part a little easier. And the eSync clinical trial in particular has some funding for both food and housing for patients who live farther than the 2 hours away. I'm now going to shift gears and we're going to have a patient interview. As Dr. Chang said, I'm excited that Mr. Doug Labat has agreed to let me talk to him about his experience in the eSync clinical trial. So I'm going to stop sharing my screen, hopefully. And I think we're going to try to set this up so that Doug and I are both visible. Is that working?
Yes, hello.
Okay. So Doug, thank you so much for being willing to do this and to talk about what your experience has been like. First, could you just tell us a little bit about you and your diagnosis and how you decided that you wanted to be part of this immunotherapy trial?
I diagnosed in May of last year with glioblastoma grade 4. So my outcome was pretty grim at the diagnosis of the outcome of surprising. And immediately we, did research on trying to find alternative methods of dealing with it. And luckily we came across our friend, neighbor, Dan Dunn, the naturalist, who happened to know, who was it? Dr. Okada doing a trial. And somehow or another, I got on the trial, and here I am, and it's been good.
That's great. The description that I just went through about the kind of the early part of the clinical trial is pretty intense with the cell collection, the apheresis, and then the 3 days of the chemotherapy, and then the week in the hospital after you get the cells. Can you talk a little bit about what that was like and if there was an especially hard part?
Yeah, the hardest part was just, like you said, collecting the white blood cells, sitting there and letting this machine separate your blood cells for about an hour. It's a couple, 3 hours. Yeah, it's like 3 hours of just, and this it was, she was just bored in the hospital after getting the T cells injected in me. Hopefully someday we won't have to do the radiation and chemo and just do this. It would be awesome.
Yeah, I'd be very excited if we end up in that position. Absolutely. Could you talk a little bit about kind of how being on the trial has affected you emotionally?
I just feel lucky. I feel lucky and fortunate that I was able to get on this trial, and so far it's been the negative MRIs that I've had for a little over a year now, close to a year, I guess, since the
Yeah, knock
T
on wood.
cell injection. Yeah.
Okay.
Instead of
And
poisoning
do you
your
have
system.
Instead of
any,
poisoning your
Your body.
system with radiation and
yeah, do you have any advice for somebody who's trying to think about whether or not this might be something that they want to
oh
try?
my goodness, this is they anybody that has the glioblastoma and has a chance to get on a clinical trial such as this. Yeah, it's fortunate to meet the criteria to do the trial, and I feel honored to have been doing it, and it's been great. The only thing I have now is I'm just a little tired. Um, Other than that, I feel good. I've lost a lot of weight because of I changed my diet too.
Nice,
I've,
nice. I do want to
my
officially say
diet.
to folks in the audience that we are not paying him to say positive things about the clinical trial.
Yeah, it's incredible. It is incredible.
Well, thank you so much for sharing, Doug, and for being willing to do this. I really appreciate it. So
Yeah, I appreciate
uh,
all that. It's all the doctors spend their time doing all this research, and here I am, still alive. Thank you,
there you
Dr.
go.
Clarke.
Yeah, our pleasure. So um, thank you. So Dr. Okada, I think we have a couple more parts of the talk to move to. Is that right?
Yes, so next section will be the final section of our scheduled presentation. So let me begin with that. Okay, so let's talk about the future of immunotherapy now. So in just the past decade, immunotherapy has transformed from an experimental idea into a standard part of cancer care for many patients. But the researchers, including our team, are working to make it more effective, safer, and available to more people. So let's look at this schema here. I drew a little bit. So today's CAR T cell therapy is only working for limited type of cancers, such as blood cancer, with some side effects, as we described. So effective treatment, CAR T cell therapy, not yet available for all type of tumors. We're trying to develop next generation of smarter and safer CAR T cell therapy for a variety of solid tumors, including brain cancer, of course, with fewer toxicities so that more patients can be helped. So our goal is really to transform many cancer types into long-term controllable diseases or cure them. So there are a few directions how researchers are developing the next generation CAR T therapy. Today's CAR T therapies usually focus on a single flag, we call antigen, on cancer cells. Unfortunately, cancer can sometimes hide that flag to escape treatment. So next generation CAR T, including our e-sync T cells, are designed to recognize multiple targets at once, like giving our immune soldiers several ways to spot the enemy, even if it changes and disguises. This approach could reduce the chance of relapse and improve long-term control of the disease. The second type of future direction is to develop off-the-shelf CAR T therapy. So current CAR T treatments are custom-made from each patient's own cells, which takes time and is costly. So scientists are developing off-the-shelf versions using healthy donor cells that can be ready to use immediately, similar to how blood transfusions work. So this could make CAR T cells faster, more affordable, and more widely available to patients around the world. So in this schema, you can see on the right side, the left side picture person says autologous. Autologous means that CAR T cells are made of the patient's own T lymphocytes. This requires costly and lengthy process for each patient. On the other hand, on the right side, I said allogeneic. So allogeneic means that T cells from one donor can be grown and infused safely to multiple, often hundreds of patients. So other people's cells would normally be destroyed and rejected in your body because of the immune system, but scientists are developing ways to prevent such rejections. Another important way is combination therapy. So cancer is a clever opponent, and sometimes one strategy is not enough. Future treatments will combine CAR T cells with other immunotherapies like checkpoint inhibitors, or even with targeted drugs or radiation. These team attacks aim to weaken cancer's defenses so the immune system can finish the job. So finally, personalized immunotherapy is also emerging. So every tumor is unique, down to its genetic code and immune environment. Advances in genomic sequencing and immune profiling are helping doctors design treatments tailored to each patient's tumor biology. So in the future, your therapy could be as personalized as custom-made suit, fitted exactly to the molecular details of your cancer type. So in the schema, I draw that personalization based on the analysis of each patient's tumor can lead to personalization not only to CAR T cell therapy design, but also checkpoint inhibitors, tumor vaccines, and other type of immunotherapy, such as monoclonal antibody therapy. So this is the end of our presentations. And thank you so much for your attention. And we are happy to answer any questions that you may have.
Thank you both, Dr. Okada and Dr. Clarke, and of course to Douglas as well for participating in this very informative and I think exciting, because here we have a new treatment that we're going to be able to offer patients, even though it is in a clinical trial and it's in a testing phase. It's still very exciting to see. And, it's a sort of translation of all of that basic research that's happened to be able to get that to our patients. That's sort of the hallmark of what we like to do here at UCSF. So there have been several questions placed in the chat. So I'm just going to go through these and ask either Dr. Okada or Dr. Clarke. So one of the questions that came up is, what other types of tumors can be treated with this type of immunotherapy? Dr. Okada?
So yes, so far, in terms of CAR T treatment, that has been proven to be effective and has been approved by the Food and Drug Administration, CAR T cells against B cell malignancies, blood cancers. However, a lot of clinical research going on on a variety of cancer types, lung cancer, brain cancer, and some other common cancer types. And also, beyond the cancer, also the CAR T cell therapy has been applied to also autoimmune diseases. So there are some exciting data showing up in treatments of like difficult autoimmune diseases such as Sjogren's disease or lupus erythematosus. Very effective. So the CAR T cells can be used to enhance the immune system, but also some researchers are using CAR T cells to suppress excessive autoimmune type conditions. So there are a variety of future opportunities. But let me come back to cancer treatment. So solid cancer remains kind of challenging for CAR T cell therapy. However, as we discussed in this series, we are making improvements in terms of multiple antigen targeting, more safer approaches, as Dr. Clarke presented for our e-sync therapy. So these rapidly developing field, and compared to 2 or 3 years ago, we have been seeing more promising signs in clinical trials field. So therefore, we are hoping that in the future we'll be able to develop effective therapies for a variety of solid cancer types.
Thank you, Dr. Okada. So I guess specifically, Dr. Clarke, what you described was for the trial is for patients who have this tumor that expresses this EGFR V3 antigen on the surface of those tumor cells. And one of the questions that was posed is, what about availability for patients who do not have this EGFR wild type, V3? So if they're wild type.
Yeah, that's a great question. So because the EGFR V3 mutation is very, very specific to the tumors that have it, it was sort of our proof of principle kind of first try to make sure that this looked like it was an approach that was potentially going to work. But as you said, this is only a fraction of people with glioblastoma whose tumors express this. And so our next version of this we are calling B-Sync, because the target that we're using instead of the EGFR is something called BCAN. And that's something that actually would be potentially much more broadly applicable to most, if not all, people with glioblastoma. So we're hopeful for that, but we have to kind of make sure that the kind of safer, first narrower version with the e-sync cells looks like that's safe and looks like there's some potential before we make that next step in the next year or two.
Great. And so, of course, what everybody is asking, I think, or thinking on their minds is, how effective is this? So in other words, if a patient has a recurrent tumor and there's an expectation of what that would be like if there was no treatment, how much do we know that this has actually prolonged a patient life or given patient more time? And, is there any information about what survivorship metrics there might be for CAR T therapy?
Yeah, and those are really important questions also that we don't know the answers to just yet, because we are still in the very early stages where we're focused primarily on the safety and making sure that we're not actively hurting people accidentally with this kind of approach. The next big question that we try to tackle when we're going through clinical trials is, how effective does it look like it is in helping people to live longer? And so it's going to take us some time before we can start to answer those questions as we see how people do with these cells.
And how many patients would you say has gone through this process? I think this is a very early, it's called first in human, a first in man type of a trial. So how many patients have gone through this so far?
Yeah, so we've treated 7 patients total so far. So it's a really small number. And that's where, we do definitely have a lot of experience to gain going forward.
So I think it's really exciting. And I think one of the other questions comes up is, is scaling this up on the near horizon? It seems very, very specific for the treatment right now, but where do you see this in terms of being much more generalizable or applicable to patients?
So I think, again, first thing is making sure that that we're safe enough as far as how we're able to give this to people, and then looking at how effective we think it might be. If things are looking good, then one of the really big questions is how do we start being able to do this for a much larger number of patients? Because right now this is, we describe this whole process, it's pretty labor intensive. You have to take your individual cells from one patient, you do a bunch of work, you give those cells back to that patient, but then the next patient who walks in the door, you're starting from ground zero again and having to do the whole thing over. And so this is where some of the things that Dr. Okada was talking about with future steps could be really exciting. If we were able to start kind of using what we would describe as off-the-shelf cells instead of needing to be your individual cells, where we could have prepared things ahead of time, that would put us a giant leg up. And so those are the things that we're working toward. Hideho, I don't know if you wanted to add anything into that.
I think your comments are perfect.
And you've talked specifically about these CAR T cells, but those aren't the only types of cells that exist in the immune system. So are there other trials that are using other kinds of cells to, take it out of the body and put it back in, or how is that working?
So if I can comment on that, yes, there are very active investigations ongoing in terms of using other types of immune cells that are also engineered with CAR. So as I mentioned, our body has many different types of immune cells, such as macrophages, natural killer cells. So our possibility, opportunity is not necessarily limited to the T cells. So there are investigations going on, CAR natural killer cells, CAR macrophages. Those are interesting areas. Those are mainly tested currently in other type of cancers. There are some trials actually using CAR NK cells in brain tumors. There are pros and cons for each immune cell type. For instance, natural killer cells are convenient. Natural killer cells are actually suitable for the off-the-shelf treatments, as I mean. This is kind of approach I mentioned to make it available for multiple patients at the same time. However, natural killer cells tend to have short lifespan after infusion, so the patient would have to receive multiple infusions for CAR NK cells in order to make up for the short duration of survival of those cells in the body. So each cell type has pros and cons, but we need to keep investigating those different strategies to find the best for brain tumor patients.
So one question that has come up is that, we're talking about glioblastoma. Obviously, that is, one of the more common and very aggressive tumors. But where do you see this for other kinds of brain tumors?
So if I can start off, we are very active investigating also developing clinical trials for pediatric brain cancers, for instance. And as Dr. Clarke mentioned, after eSync, which requires EGFRvIII expression, we are developing version 2.0, which is BSync. It doesn't require EGFRvIII expression, so that because BSync, B comes from BCAN, which is a primary antigen in the brain. Everybody's brain has this BCAN expression. So in theory, this can be applicable to any kind of brain tumor. So we are testing in the setting of pediatric brain tumors and multiple different kinds of pediatric brain tumors, and also EGFRvIII negative glioblastomas or potentially lower grade gliomas. So we are actively developing ways to expand the applicability of this strategy to a variety of brain tumor patients.
Great. Dr. Clarke?
Just to add one small other additional thing, I think one of the questions that often comes up for folks is, what about people with IDH mutant gliomas? Is the IDH something that we could potentially target with CAR T cells? And the answer for that actually is, unfortunately, that's not easy to target because it's not something that's expressed on the surface of the cell where the immune cells can see it. It's something that's deep inside the tumor cell. And so that makes it not so helpful for this kind of immune cell strategy.
And then one question that came up is about if you're familiar with Sovaxim and what that is and the type of immunotherapy.
Yeah, so I can maybe briefly describe it, and then Hideho may have some additional information that he can add. So Survaxim is it's a vaccine. It's a peptide vaccine. So the goal of that, like vaccines against infections, the goal is to give the vaccine, peripherally into your arm and to help the immune system to recognize that survivin protein that's expressed by tumor cells, and then to hopefully have the immune system be able to recognize and attack the tumor cells that are expressing that. And so it's, the idea is the same of helping the immune system to recognize something foreign about the tumor cells. The strategy with the vaccines is to get your own immune cells that are living in your body without us having messed with them to go after the tumor, as opposed to the CAR T cells where we're specifically engineering them.
Any other comments, Dr. Okada, about it?
Well, that's another perfect response. So it's a strategy to train patients on immune system in the way that the immune system recognizes the survivin as a cancer relatively specific target, so that immune system can attack the cells expressing survivin. Although survivin is a intracellular protein, like Dr. Clarke explained, it exists not on the surface of the tumor cells, inside of the tumor cells, but this small fragment of this protein can be presented on the surface by a molecule called major histocompatibility complex, so that T cells can still recognize it, just like T cells do against cells infected with virus. So it's a smart system suitable for vaccine strategy.
So here we are talking about vaccines, and we know how successful mRNA vaccines have been for COVID, for example. So one of the questions has come up is, what about mRNA immunotherapy for brain tumors?
I'm going to let you answer this one,
Dr.
Dr.
Okada.
Yeah, so yes, I have been very keen on developing novel type of vaccine strategies for patients with brain tumors. RNA-based vaccine is one promising strategy, but in my own opinion, it doesn't necessarily have to be mRNA. It could be done by well-designed peptides or DNA vaccines, or some people actually use viruses to make good vaccines. And so there are a variety of ways to develop effective vaccines. There are lots of research going on. I'm very keen on getting cutting edge information about vaccine technologies. And I'm also hoping to be able to develop very good vaccine strategies for brain tumor patients. We have done a few clinical trials for pediatric brain tumors and also lower grade glioma patients. And we'd like to continue our efforts to that line of developments as well.
Great. Well, we're just coming up to 8:30. There are a couple other questions, and maybe I can have those directed to either of you maybe afterwards. But one of the questions is about collaborating with other centers like UCLA, and I know there's also someone asking about UPenn and the different trials that are ongoing at various places. So maybe Dr. Okada, quickly about how do centers participate in trials that are different, and how does that work?
Sure, sure. Yeah. For a variety of reasons, for the phase one trial, we tend to do it as an institutional trial, single center trial. So UPenn has its own trial, UCLA, City of Hope, etc. But eventually, we are pretty well connected and very collaborative in heart. So we are always talking about we are networked very well. We are members of, say, for instance, Parker Institute for Cancer Immunotherapy. So this is a collaborative group for cancer immunologists to work together collaboratively to develop something innovative for patients. So after the phase one, which is to test the safety first and close monitoring of local patients, that is the idea. But after that phase, we are ready to develop larger clinical trials so that we can treat patients across the nation or even internationally.
Great. Dr. Clarke, your last words on that?
I think Dr. Okada covered it really well. These early stages, it's really hard to try to do anything except have stuff all done exactly the same way at the same institution so that you're kind of minimizing inconsistencies. But obviously, it doesn't really make any sense to be developing a treatment that has to be done physically at UCSF. That's not going to work, right? So we do have to think about how do we collaborate with other people, get other centers to be able to do things if it looks like they're working. How do we spread this knowledge around? And everybody's very motivated to do that. So there's one of the other networks that UCSF participates in is called the Glioma Therapeutic Network, or the GTN, and that network actually was part of some of the funding that has helped us get the eSync trial off the ground. And people are chomping at the bit to be able to try things at their own institutions.
Wonderful. So I want to thank again Dr. Okada, Dr. Clarke, and Douglas for participating and presenting in this. I think it was a wonderful webinar. All the questions were all from you guys. I didn't bring this up myself. So this is amazing how interactive you guys are and engaged, and I really appreciate that. I want to thank Lacey and Judy, and Naomi, actually, who behind the scenes has been helping with this. So thank you so much for that. And I think now, Lacey, for those who can stay on for the next half an hour or so, this is going to be part of your support group. So I'm happy to stay on as well. Please stay on, be happy to stay on. And just know that the recording is going to be available for you. So I hope you weren't taking notes, scrambling to take notes, but the recording will be available, and we're actually going to be having a video series with small segments of the talks so that you can watch them in bits and pieces at your own time. So you don't have to wait to go through the whole entire presentation. You can sort of pick and choose. So thank you very much, everybody. And again, I want to thank the Sherry Sobrato Brain Cancer Survivorship Program. Thank you. Lacey, I'm going to give it back to you.